Assalamu alaikum. In this video, we are going to discuss about esophageal motility disorder. Actually, there are many types of esophageal motility disorders, but mainly here we are concerned about important issue, that is Achalasia cardia. It is important from your exam point of view, though it is rare in daily life, but we have to study because of our exams, because we have to pass our exam. So normally just try to understand the normal structure, that this is the normal esophagus and after that comes the stomach. This is the normal stomach, and in between these two structures there is a sphincter which is called LES or lower esophageal sphincter. Whenever food comes, this lower esophageal sphincter just relaxes, due to which that bolus of food can easily pass into the stomach from your esophagus. But in the case of Achalasia cardia, what happens? Before going to Achalasia cardia, just understand that there are two things in your esophagus. There are two things mainly. One is muscles and number two thing is nerves in your esophagus. But in Achalasia cardia, there is dysfunction of both the muscles and the nerves. But initially and especially there is dysfunction of the nerves. Mainly the let me draw a flow chart that whenever food or bolus comes, right? Whenever food or bolus comes, peristaltic contractions occur. Okay, peristaltic contractions, you must be knowing already about the peristaltic contractions that occur in the esophagus. I will show you in the later picture about peristaltic contractions. After peristaltic contractions are generated, these peristaltic contractions, when it comes to the lower esophageal sphincter, it stimulates the inhibitory neurons of the myenteric plexus. There is a myenteric plexus in the, it is a nerve plexus or myenteric plexus which is present in the esophagus. When food comes, then inhibitory neurons in this myenteric plexus are mainly stimulated, due to which nitric oxide is released. And nitric oxide, you know already that it is smooth muscle relaxer. It causes smooth muscle relaxation, due to which smooth muscles in the lower esophageal sphincter are relaxed and food can easily enter into the stomach, right? I can repeat it. Food comes, peristaltic contractions of esophagus occurs, stimulation of inhibitory neurons in the myenteric plexus occurs, and after that nitric oxide is released and it causes relaxation of smooth muscles in the lower esophageal sphincter, and as a result lower esophageal sphincter relaxes and food can easily go into the stomach, right? But in the case of Achalasia cardia, there is dysfunction of both the muscles and the nerves in your esophagus. Normally in your esophagus both muscles and nerves are present, I have told you before, but here what happens that both muscles and nerves are dysfunctional, and mainly and especially and initially the nerves are affected, due to which the sphincter, that is lower esophageal sphincter, that is present between this esophagus and the stomach, it doesn't relax at all, right? It contracts and it doesn't relax at all, due to which food cannot pass from the esophagus into the stomach. Number two thing that happens here is that the rhythmic contractions of the muscles, the contractions of the muscles which are responsible for the peristaltic waves generation into the esophagus, are also lost, due to which peristalsis doesn't occur correctly. You can see here clearly in this picture that this is the normal esophagus, right? Whenever the food bolus comes, this is the food bolus. It has passed from the upper portion into this portion, and when it comes here, the previous portion of the esophagus has constricted, but the next portion has been dilated. And when food has come in the next portion, then previous portion again has contracted, but the next portion has opened, and similarly lower esophageal sphincter has also opened. So these are the normal peristaltic contractions, but these peristaltic contractions are not normal in the case of the Achalasia cardia. Here again in your book in Irfan Masood, it has written that it is esophageal motility disorder with three major abnormalities. It is mainly a triad. Triad consists of three things you know already. Number one is there is failure of lower esophageal sphincter to relax with swallowing. Number two is that there is loss of peristalsis, I have already discussed. And number third thing is that there is increased tone of lower esophageal sphincter. We have talked about it a lot. And similarly, I have also discussed about the pathogenesis, that there are normally myenteric plexus in the esophagus, and here are some inhibitory neurons in that myenteric plexus, and whenever food or bolus comes, there is stimulation of those inhibitory neurons in the myenteric plexus, and that releases nitric oxide or vasoactive intestinal peptide, and as a result smooth muscle contractions don't occur, or we can say smooth muscles relax, due to which lower esophageal sphincter also relaxes. But all of these things do not occur in the case of achalasia cardia, because there is degeneration of those inhibitory neurons, there is no nitric oxide release, no smooth muscle relaxation, no lower esophageal sphincter relaxation. So that is the pathogenesis. After that comes the causes. There is mainly achalasia has two types, or it can be some other causes, but mainly we classify it into primary and secondary causes. Primary causes include whenever there is any dysfunction of the esophagus itself, but here are written some secondary causes. You can remember it by mnemonic SAD, pseudo, chaga. Remember that chagas or shagus, mainly we read it as pronounce it as shagus. Okay, shagus disease. You can remember it by mnemonic SAD, pseudo, shagus. Remember that shagus is a person, just for your mnemonic. S for sarcoidosis, A for amyloidosis, D for diabetes, and pseudo for pseudoachalasia. It is mainly a cardia tumor. You know that cardia portion of your stomach. If there is any tumor of the cardia, then it also produces symptoms just like achalasia cardia. So in the case of pseudo achalasia, there are also the symptoms like achalasia. After that comes the Chagas disease. In Chagas disease, it is caused by a microbe, that is Trypanosomia cruzi, and it mainly occurs in Americans or America. So it is also called American trypanosomiasis. So it is an infection. So in the case of Chagas disease, there can also achalasia cardia can occur. After that comes the clinical presentation. You don't have to cram it. You just you can easily remember it, that if just suppose that if someone's lower esophageal sphincter is not working, then what can happen? Dysphagia will occur because food or bolus is not passing into the esophagus after some bites or after eating some bites. Dysphagia will occur. Initially it is intermittent dysphagia कि कभी कभी dysphagia हो जाता है, after that it becomes persistent dysphagia पहले पहले जो है वो solids के लिए होता है, after that it is also for liquids, and initially it is for solids, फिर semi solid foods के लिए भी और फिर liquids के लिए भी dysphagia हो जाता है. Age is mostly less than 50 years. Weight loss will also occur as person is not eating anything. He or she is unable to digest. He or she is not able to pass down the food. Either it is solid, semi-solid, liquid. So weight loss is obvious. And similarly, heartburn here doesn't occur. As in the case of GERD, we studied that heartburn will occur. Patient would complain of the heartburn के जलन होती है सीने में उसको. But in the case of achalasia cardia, there is no heartburn. Why nocturnal cough and regurgitation can occur? Because food has not passed down into the esophagus. So when the person is lying down or at night time, what can happen? Regurgitation can occur. And if this you know that in front of esophagus there is larynx and trachea and the whole airway. So if aspiration of that content has occurred into the larynx, then it can result in nocturnal cough, laryngitis, and many other symptoms, but these are its complications. After that comes the diagnosis. For diagnosis, mainly esophageal manometry is gold standard or diagnostic for achalasia cardia. In manometry, you measure the pressure of the lower esophageal sphincter, and you know that in achalasia cardia there is increased pressure of lower esophageal sphincter, so you will find it. And manometry is mainly used for measuring the motility of the esophagus. Like in GERD, you will find that lower esophageal sphincter's pressure has been normally reduced even in resting state, but in the case of achalasia cardia, lower esophageal sphincter's pressure has been increased. It doesn't open at all. And similarly, we can do barium swallow. In barium swallow, we give barium sulfate, which is in powdered form. We mix it into a liquid, we pour it into a liquid, and then we ask the patient to swallow it. When patient swallows it, we take the plain x-ray. ठीक है. बैरियम सल्फेट क्या होता है? एक रेडियो एक्टिव मटीरियल होता है. आप पेशेंट को पानी में डाल के किसी भी लिक्विड में डाल के दे देते हो स्वेलो करने के लिए, फिर आप एक्सरे ले लेते हो, एंड यू कैन ईजिली सी द status of the patient's esophagus. As it is a radioactive material, suppose that this is the esophagus and here is some constriction. When the patient swallows the that barium sulfate, then what happens, as it is a radioactive material, you can easily detect it on x-ray. It is radiopaque, it will show white colored on x-ray. Barium will come here, and as it there is some constriction, so barium will not go down into it. So here you can see radio opaque material of barium. So in the case of Achalasia cardia, like this is the lower esophageal sphincter and here is constriction present. So you can see here that this is the portion of the esophagus that is dilated, and it mainly dilates in the chronic cases. In the portion of the lower esophageal sphincter, there is bird beak sign, but behind it there is mega colon in the chronic cases. It has just dilated. The portion of the esophagus just behind this constriction has dilated. Like you can watch it from here that it has been showing a bird beak sign here. After that just comes the treatment. You can give pharmacological treatment in which you can give nitrates to the patient, calcium channel blockers, as they are mainly smooth muscle relaxers. They will also cause the relaxation of the lower esophageal sphincter, so we can give them pharmacologically. And similarly, you can also inject botulinum toxin. You know that botulinum is mainly responsible for blocking the acetylcholine receptors. This is presynaptic nerve ending and this is post-synaptic nerve ending. On post-synaptic nerve ending there are acetylcholine receptors, and botulinum will mainly do what, it will block these acetylcholine receptors, due to which there is no nerve impulses generation, no nerve impulses passage, due to which we can say there is blockage of the nerve impulses, due to which there will be no muscle contractions, right, and muscles will relax. Lower esophageal sphincters muscles will relax. Then comes the non-pharmacological treatment. In non-pharmacological treatment, you do pneumatic dilatation. I will show you its picture. You can watch it clearly here that it is endoscopic guided. Endoscope is also passed. Endoscopic pneumatic dilatation. Here dilatation of lower esophageal sphincter is done. You do what? You just pass an air-filled cylindrical shaped balloon, and when it is passed into the lower esophagus phageal sphincter, when it comes into the LES, you just dilate this balloon, and as a result of its dilatation, lower esophageal sphincter's muscles are torn and its force of contraction is reduced and lower esophageal sphincter muscle just relaxes. After that comes the surgical myotomy. We also call it as Heller's myotomy. In this myotomy, you do what? You simply do the cutting of the lower esophageal sphincter muscles. Like this is the lower esophageal sphincter. You simply cut the muscles of the lower esophageal sphincter. Lower esophageal sphincter is here opened by cutting the thick outer muscle tissue between this esophagus and stomach, and it can also be done non-invasively, as it is a laparoscopic procedure. You can do simply laparoscopy, and as you are cutting the muscles of the lower esophageal sphincter, so there will be chances of regurgitation of the acid into the stomach, from the stomach into the esophagus. So you also do partial fundoplication. In fundoplication you do what? I have also explained it in the previous video of gut, but I am explaining it again, that you just put the lift the portion of the fundus of the stomach up, and you just wrap it around the lower esophageal sphincter. Again, this picture is showing Heller's myotomy. Laparoscopic cameras are placed after that myotomy is created. It means muscle is cut at the site of the lower esophageal sphincter, and after that fundoplication is done, fundus of the stomach is lifted and it is wrapped around the lower esophagus. And last but not the least, it is minimally invasive procedure and it is expensive, but it is gold standard for Achalasia cardia. This is POEM procedure, per oral endoscopic myotomy. In this procedure, what is done? Incision is made in the mucosa. Okay, you do what? You give a nick in the mucosa, incision in the mucosa, and like this is the mucosa, an incision is given here. A submucosal tunnel is produced in the submucosa. You just run your instrument, and this is endoscopy guided again. You just, when you just come to the lower esophageal sphincter, you cut that lower esophageal sphincter, and you see that either the lower esophageal sphincter muscle tone has been reduced or not, right? And after that, that nick that you have produced in the mucosa, that is just tied or recaptured again by a clip. Like you can see here that this is the mucosa. You just give a nick in the mucosa, you just pass the instrument into by creating a submucosal tunnel. Here in blue color, the light blue color, this is submucosa. So submucosal tunnel is produced, and after that you just come to the position of the lower esophageal sphincter. You just cut it to your desired level and see that either it's lower esophageal sphincter's pressure has been reduced or not. And after that, you mm, just put this instrument outside, and a clip has been placed at the side of this mucosal neck, right? So I hope so that this will be clear to you. Thank you very much.